My name is Omar Zidan. I come from the Procure Proton Therapy Center in Oklahoma City. I'm the speaker and the sole moderator for this session. We're going to talk about overview of quality assurance in proton therapy. When I designed this course initially, I had a lot of things in it, and I decided to scale back because I remember that most of the attendees are actually photon physicists. So if you're a proton physicist, hopefully you're not going to get bored, but at least consider it as a refresher. So what are the learning objectives of this course? First, understand the proton beam dosimetry characteristics and compare it to photon beams. I'll talk a little bit about the physics. It's imperative that we understand those beam characteristics at depth before you go into QA devices and how we do QA devices, because you want to do QA to actually monitor or assess those beam characteristics over time. We can also familiarize ourselves with proton dosimetry tools, whatever is available at the moment, and understand some of the challenges in proton therapy QA and operational challenges as well that comes from working in a proton therapy center. So this is a map that displays the locations of currently clinically operating centers in the U.S. There's a total of 10 of them. 3 are Procure centers, and the rest are mainly academic or all academic-based centers. They treat roughly several thousand patients a year, but still under 1% of total external beam radiation therapy. So the field of proton therapy is still pretty small. But I applaud APM willingness to give me the opportunity to talk about QA at this moment because, as you all know, there is significant interest in protons, and it never is too late to be proactive, to educate and raise awareness between photon physicists, because that's where we're going to draw from. The proton therapy field will draw from photon physicists to understand the issues and the physics of proton therapy. What I'm showing here is a layout of a Procure Proton Therapy Center facility. Most of those facilities that I showed you earlier are 3 to 5 room centers. Basically, you have at the far left a source for protons, generating protons and accelerating protons. It could be a cyclotron or a synchrotron, feeding protons into a beamline and then into several rooms. The rooms are, could be configured differently. Sometimes we have 3 gantries or 1 gantry in this case, a fixed beamline, and whatever configuration in between. Or it could be all 3 gantries and 1 fixed beamline, but you get the idea. Most of the desired energy that we get out of those accelerators are close above 200 MeV, close between 230 to 250 MeV, that generates enough range in tissue beyond or close to 32 cm, more than sufficient to treat most tumors. One distinct difference between a facility like this and photon clinics is that each room does not have its own beam generation capability, which means that you have to request beam, you're going to have to wait in turn until you get beam, because you can only beam in 1 room at a time. So utilization of beam and optimization of beam usage is of utmost importance in this business. Notice that the amount of heavy shielding compared to X-ray clinics, and you need that to shield from neutrons that are generated when protons are hitting high Z materials, and generate neutrons of all different energies that need to be shielded. So you have high density concrete everywhere, several feet of thickness, which adds to the cost of these facilities. This is just pictures of the Oklahoma City treatment rooms from the inside. On here you see the fixed beam room, and by definition, from its name, it just provides beam from a single direction. You got the gantry, which provides beam from 360 degrees, and 2 rooms that provide beam from 2 different angles. There's imaging systems, there's a robotic couch and other things, and we'll talk about that in detail in the next slide. So if we get a panoramic view of one of the treatment rooms, and we'll pick the fixed beam room for simplicity, you can see that there are major components here that are different. There are similarities to X-ray treatment rooms, but the major differences are obviously in the beam collimation system and beam delivery system here. We call this the nozzle, and attached to the nozzle are snouts with different sizes to further collimate the beam. You have an X-ray source, and you can see those in those two panels. This panel can swivel to this side, and you can get 3 sets of different X-ray images, 3 sets of orthogonal planes. You have X-rays in the nozzle itself, on the wall, and on the floor. And this is a 6-degree freedom robotic couch with a carbon fiber top and with a weight limit of 450 pounds. You got a pendant, you recognize that. Then we have also lasers, but the lasers are not used as we would, as we use them. We don't heavily rely on your lasers because this is an image-guided treatment system. So basically what we care about in our QA are these 3 following items: the imaging system and its isocentricity with the proton radiation isocenter, the positioning system, and beam delivery itself overall. This is the focus of the QA. So in order to go further, we have to also talk about the beam delivery systems. I mean, there are 3 different ways of delivering beam, but the beam spreading itself falls into 2 main categories, passive scattering and active scanning. So basically, the beam that you get out of the cyclotron or synchrotron have a field width half max of, say, 2 or something, 3 millimeters. It's not sufficient to cover the tumor and treat the tumor in a sufficient time. So what you do, you have to spread it some way. And one of the ways of spreading it is actually, putting something of high Z material as a scatter in the beam path, and you do that in the nozzle inside the room. Or you design it in a way that you have scanning magnets, because these are charged particles, that allows to wobble the beam at high speed and, deliver that beam that way. So whatever choice it is, you just have to do something about the beam to cover the target you need using either of these methodologies. Now, some of the systems like uniform scanning, which is the exclusive delivery methodology that Procure uses both. You have at least one scatterer, and then after that you use the magnets to wobble the beam. So let's talk about the 3 different beam delivery techniques. DS or double scattering is the most prevalent type of scattering system out there. What I'm showing here on the left is the beam path as it goes through the modulator wheel and the first and second scatterer. And then when you scatter the beam, by the end of scattering the second time, it's wide enough that you need to collimate it, put in a compensator. And if you look along the beam direction, you can see, for example, a circular aperture. The entire aperture is actually filled with protons, or at any time in the entire aperture protons are passing through it because it's collimated, and at depth they deliver dose in this fashion. You have a PDD with an SOBP or spread out Bragg peak, and this is just a typical spread out delivery that you can see here. Now this entire delivery, or this in yellow, this entire area is covered almost instantaneously. You have the modulator spinning at very high speed that allows the Bragg peak at the distal end to be delivered, and then very quickly all the other subsequent ones with different weights to give you this. Uniform scanning, on the other hand, does use a modulator weir for first scatter, but then it goes through a scanning magnet 1, a scanning magnet 2, or X and Y, and then the beam is wobbled in this fashion. If you're riding along the beam, you'll see the aperture with the beam going in this direction and back and forth, 3 hertz in this direction and 60 hertz in that direction. But so it's not the spread out pencil beam, I would say, which is roughly 3 cm at SAD, is not filling the entire aperture. But the end effect is that after you paint all these layers, retract them layer by layer, you get the full effect or the full coverage, just like double scattering. Moving on to the third type of delivery, you have pencil beam. Pencil beam is a lot more sophisticated to deliver. The control system is sophisticated. You got scanning magnets. You scatter the beam slightly just to spread out, anywhere between 3 millimeters to a full centimeter, and then you control the intensity and depth actively. And at any given point, you look at the aperture, you got dots, and each dot has different intensity. You track that, and you get conformality at depth just like that. So it's just like a series of Bragg peaks that are delivered very fast fashion and then distributed, optimized in that volume. Now, one distinct advantage of pencil beam, obviously, is that you don't have to use patient devices like apertures and compensators compared to uniform scanning and double scattering. But at the same time, you have this complexity of QA that comes along with this highly sophisticated delivery. One of the advantages of uniform scanning over double scattering is that when you scatter the beam multiple times, you increase the penumbra, and you also reduce the maximum range that the protons can use. So, for example, although University of Florida has the same cyclotron like ours, the deepest they can deliver the beam 2 cm less because they've scattered the beam so much, and their penumbra at depth is slightly different than ours. So what are the beam characteristics at depth? You've seen this everywhere. You got a comparison here, one-dimensional comparison of photons versus protons, and you can see that if we're going to cover a hypothetical tumor size at that depth, you can do it with a single spread-out Bragg peak, but with photons, you just have to, if you normalize at the tumor center, you'll get this kind of distribution, indicating that the photons go right through the tumor and deposit those significantly before and after unneeded dose to healthy tissue. But then, a critique of someone from the photon world will say, well, we never really treat that way. That's true. We treat maybe with 2 beams. So if I compare 2 PDDs, opposing PDDs of 6 X-rays to cover this tumor, hypothetical tumor at this depth, say 6 cm between the depth of 13 and 18 cm, or 5 cm depth or 5 cm thick target, you still cover it just fine with an SOBP proton beam, but you have this significant and uniform dose with 6x, but you got all this yellow area that is irradiated unnecessarily. In fact, for any given volume, if you compare this size of target with this type of delivery, protons will deliver the full dose to half of the volume that photons would deliver using this technique. So there is some sort of a clinical advantage right there, just having protons stop where you want them to stop. So let's look more closely at the SOBP anatomy, because we're going to use those terminologies as we go along in describing QA protocols and QA devices. This is straight out of ICRU 78. What it shows that the definition of some of the parameters we use to describe or characterize this beam. You got the range. Range is defined from the surface to the 90% distal end, which is basically the distal point is the point where the dose falls to 90% of the prescribed dose. The prescribed dose normally is the dose or in the middle of this modulation area, assuming the modulation area is flat. M stands for modulation. It defines from between this point, the proximal 90%, to the distal point, the distal 90%. At Procure, we use a modulation 95 to 95, and this has something to do about our delivery system. But, there are guidelines to tell you that you could use whatever you want, but, this is what in ICRU 78, as long as you're consistent. Reference point is the point where you would place your detector at, normally in the middle of the modulation, and this is also where you measure symmetry and put in point dosimeters there to report absolute dose or relative dose for that matter. The distal end penumbra is the penumbra from 80 to the 20% fall off. So what I'm showing here is just how you construct an SOBP is by deriving a series of those Bragg peaks, retracting them and weighting them differently till you have a flat top. If I take a penumbra right here, perpendicular to this plane, you will get what you expect as a penumbra. You're going to have a step function that falls in with this fashion, and the distance between the 80% to 20% is the penumbra. similar to photon therapy. Our criteria in our institutions, and we established criteria recently, and we think it still is generous, is we have a flatness within 5%, symmetry within 3%, and range within 1.5 millimeter. In fact, we deliver tighter than that, and we verify it on a daily and monthly basis, and it's actually within a millimeter. And we have a modulation width within 5 millimeter. Now, that might be slightly different for double scattering, and certainly different probably as well for pencil beam. So let's talk about lateral penumbra. This is a very important feature of proton therapy. Data from our institution show that the penumbra for X and Y magnets, remember there are two magnets in the nozzle, so they have slightly different penumbra, but for all practical purposes, we're going to actually just look at the average of those. You can see that it ranges anywhere between roughly 3 millimeters at very small ranges all the way to 8 millimeters or so for clinically meaningful depths. It remains steadfast for the first few, up to 15, and then goes up slightly. But still, I mean, it's pretty tight penumbra, and this is again one of the advantages of proton therapy is that you can deliver a beam that's very close to critical structures to treat a tumor that's very close to critical structures and get very close without having to worry about delivering unnecessary dose. But also it helps you during treatment planning is that it reduces the actual area covered by the aperture, because if you design the aperture to cover the PTV, you have to only go a few millimeters beyond the PTV to to put your aperture edge, which means that you're delivering less volume compared to photon therapy. So let's see what photon therapy dose penumbras are there. So I have 3 data points here showing the 10 MV penumbra, and you can see it's anywhere between 50 to 80% higher than what you expect from proton therapy. The main reason why we have tighter penumbra is simply the physics. Protons are very heavy, and when they move in tissue at very high speeds, they don't really scatter too much. They go through nuclear elastic collisions, and when they collide with the nuclei along their path, and those are the ones that cause this lateral penumbra. But another interesting thing about this is that most those delivery systems, proton delivery systems, have an SAD that's actually twice as large as X-ray therapy. LINACs have an SAD of 100 cm. Most proton systems have 200 cm or so. So despite the geometrical disadvantage, you still have protons beating most X-ray penumbras at various depths, which is very good news. Now, what about the distal end? The distal end also changes with depth. And it doesn't change as fast as lateral penumbra, so it changes anywhere between 3 millimeters or 4 millimeters to up to 5-6 millimeters at meaningful depths. And the reason that this bump has something to do with the way we deliver beam in our IBA system. There's no need to go into details, but the idea is that it does increase with depth, and that's actually coming from energy straggling. If you think of a point at depth where the proton is going to stop at the very end of the delivery, okay? You can imagine as the path increases in length, there are more chances, there are more pathways for the protons to get to that point. So basically, the protons stop at that point, at the distal end, with a slight energy spread, and that's what we call energy straggling. But this is important clinically because when you do patch fields, the cold and hot spots are completely controlled by the fact that the interaction between this distal fall-off and the and the lateral penumbra as well. Excuse me. Another important difference between photons and protons at depth is what happens when you put some sort of a heterogeneity in the beam path. We all know for photons, what happens is that you get slight attenuation and reduction in fluence, but there is still dose coverage before and after the introduction of this heterogeneity. In this case, it's a bone material in a cobalt-60 beam. So basically, you don't really lose energy, and coverage is pretty much the same. Protons are totally different. If you put anything there, it will retract the entire SOBP beam. And you notice that it doesn't affect the modulation itself. The M remains the same. It's just the entire delivery is kind of shifted to the left. That amount of shift, I'm showing here 3 and 2, which is a little misleading, but it's pulled back by the amount of tissue equivalent material that you put in there. So if it's, for example, let's say you put in a bone or sponge or anything like that, the equivalent water equivalent depth of that material is what's going to be pulled back by. So for example, in this case, although this is 3 cm geometry, its water equivalent depth is only 2 because that's the areal density that we can see. For that material, and that's how much we pull back. If you put in 2 cm of water or 2 cm lucite in front of here, that's how much this entire SWP delivery will be shifted by. So basically, protons are very sensitive to what's in the beam path, and they lose energy or degrade, and the influence is the same across the heterogeneity, before and after the heterogeneity. It's just the entire thing gets shifted. Now, keep in mind, this is also a very important thing to understand, because at any given point at depth, we still have photons here. We completely lost protons here. There's no dose delivery. So we have to be very careful about what we do in the beam path. Even when you do QA, I mean, like, the wall of the, of your QA device, or like a container water tank, is actually have to be accounted for, because it pulls back whatever water equivalent depth of that in that direction. So this is something to be mindful of. Now let's see how we can manipulate the SWP beam. If I have a beam that's delivered on a surface of a phantom of water, you get the modulation and range in this fashion. If I put in front of the beam a water equivalent depth of x, it will pull the entire profile by x in this direction. If I put in x and y equals modulation, it'll pull the entire thing by that modulation. So what does that mean? That if I place a detector right there at the beginning, in this delivery with nothing, the detector will actually detect the proximal end of the modulation. Over here, the detector is in the same place, but it's actually measuring those in the middle of the SWP, and in this case, at the distal end of the SWP. The collection, the charge particles or the charge that we collect from the detector reading in all these 3 places fully characterize the entire the entire delivery. You have output over here. You have a signal here should match this signal here, and then this way you know if you deliver that beam or not. You don't have to do more than 3 points to characterize that. And every SWP delivery with a certain range of modulation will give you different detector readings. But now we understand that we can actually, as long as we, and the reason we're trying to do this is that, beam time is precious in proton therapy, so you have to be aware of the fact that you need to design your setup so that you can QA as much of the beam characteristics as possible with the least amount of beams. So we have to be smart about how we design our QA devices so that with a single beam delivery we can check for several of those characteristics. So for example, you can take a compensator and take a quadrant of that compensator and say, okay, well, I'm going to add something over here. So let's say 2 cm to check some side or one point on the SWP beam, and the rest will be the same. In fact, if you deliver it, you take a film of that, you can see that, surely enough, for a circular beam, it's retracted by that amount. So you can use this concept, take one of those commercially available devices like this one, put it in an in-house phantom. This device is used normally in photon clinics for morning warm-up. They have already different build-ups in front of the detectors. You can add different build-ups in front of them. It doesn't matter where you pull the build-up, as long as you have several detectors, a single beam delivery, and you can play with that build-up to give you all the data points you want to characterize your beam. Or you can design also multiple or slightly different thicknesses of lucites in different rooms, and that's what we have in our facility, and each room will check a different range of modulation every day. So one of the most important aspects of QA, now that we understood some of the basics of proton beam characteristics at depth, is to look at how we do QA devices for patients, output and mechanical, and also do hardware QA. On the machine itself and the beam. Just introduction terminology. This is the IBA universal nozzle. attach it as a snout, so the snouts come at the or get attached to the very front of the nozzle. This is a massive structure. These things are also very massive anyway, between 300 to 450 pounds. So you need special equipment to actually snatch it in here or put it in place, and attached to those are actually the patient devices that we need to QA. And here's an example. At some point we were started with lucite. We switched to wax. Wax is easier to machine as a compensator. The wax and apertures, the apertures of the wax and the lucite come attached to the front of the aperture. Some of them are machined in house, and some we outsource to a vendor. But this is the kind of sequence we have, and we want to make sure that every patient has the right aperture or right compensator. To remind you of what's the purpose of the compensator in proton therapy is if you don't have a compensator, you deliver a beam, and look at the 9 region here to be your prescription region, you'll find that you're covering the targets fine, but you're over covering because your beam has went through an air cavity over here, so it's overranged. So this is undesired dose. Well, the aperture, the compensator takes care of that. So when you design your compensator right to account for this heterogeneity by adding more material so that the pullback is the same, you get this conformality. Now remember, you still cannot do complete magic with protons. You have this extra dose that's come here, and that's fine because your beam is delivering only one set of modulation or one value of modulation. So if you measure any 2 points from here to here, anywhere, it's a fixed value. So when you modulate around the target like that, you have this extra dose you cannot do anything about. But arguably, you can have with pencil beam better or less contribution in this area. Okay, so what I'm showing here is a wax compensator. This is a prostate wax compensator. You can see that it's thick for tissue around the bone, the femoral heads. You just imagine that you're riding along the beam, seeing the femoral heads, and it has the least amount of material right where the femoral heads are, and that's what you want, because if you want to conform the beam at the distal end of the prostate from one lateral delivery, you have to allow the beam to go through as much wax as possible, because it's going to go through the bone, which is high density material. It has a higher stopping power ratio compared to that of water. So this design is shipped to the CNC machine with a certain width of the drilling machine that we have 4.7 millimeter radius that goes in a plunger fashion and designs this compensator. So it basically translates what the treatment planning system here shows as a map of the iso thickness lines. So we use the axial treatment planning system, and it gives us this iso thickness lines, and the purpose of mechanical QA is to compare this to this. And you do it the old-fashioned way with the mechanical plunger with a micrometer, and you get to digits here of sub-millimeter accuracy. But it's a long process. It's tedious, and you can only check for a few points. Luckily, we have a training and development center in Bloomington, Indiana, for the Procure system. We have engineers and physicists there that help us improve things, and they come up with this very nice device that has motion. It's a motion platform in X and Y with a laser that you put the device in and you turn it on, and it'll just go and validate as many points as you want, and generates a report that goes into the patient medical record showing all the points that was checked. And it just improves efficiency considerably, and it's very accurate, user independent. How do we do? What else do we do for patient devices? We measure output factors. Some of that, for example, here I'm showing, a weird-looking shape for an aperture projecting the beam's eye view of that tumor from that angle. So to do QA, to figure out what the output factor is for this shape, we put in a 10 cm aperture. This is our reference aperture, and then deliver a certain amount of marionettes, 100, 200, 150, as long as we're consistent. And then we place them in solid water or regular water, one detector value here at the depth of 11 cm, which is the middle of the modulation. R16M10, stands for range 16 modulation 10. This is our reference beam. Now, there's nothing to special about this particular beam, but as long as you call this your reference beam, that's what you stick for all measurements after that. So once we get the value from here, with this aperture on and this aperture on, we ratio out the readings per mile unit for each one of those, and we get the output factor for that particular aperture. And we do it for every aperture for every patient. Something about, or a little bit about the physics of output factors and their dependencies. Unlike photon therapy, I mean, photon therapy heavily depends on the field size. The field size basically dictates the output factor at depth. With protons, there are actually several factors. Those are the most pronounced. The output factor versus range and the output factor versus modulation. So let's try to explain this very quickly. The reason that the output factor increases with range regardless of modulation is the fact that the protons that are more energetic, translating, i.e., more range, deposit less current, or sorry, less dose or less ionization, less density in the MU chambers in the nozzle compared to the low range one, and hence, regardless of modulation, the more range there is in the beam, the more energetic the protons are, and they deposit less ionizations in the ion chamber. And hence, that's how you get this pattern. Why does it change? How does it change with modulation? Actually, as output factor drops with modulation, and this is a different reason. The reason here is that as you increase the modulation, you're increasing the volume that the protons need to treat. And as you increase the number of protons, there are more protons going through that monitoring chamber, and that's why, in order to be delivering the dose you want in the middle of the modulation, so as you deliver more proton beams per beam, you get lower number of monounits because there is more protons to deliver those in the monounit chamber. Now, other factors, and there are posters about that. I would encourage you to review from our group in Oklahoma City on field size, snout position as well, phantom material itself, and dose rate. So if you want to study all of that in modeling, it's actually not easy. It's very complicated, but that's why we have to do measurements for every patient. Now, we got to the point where we don't do it for prostates, but everything else is still, we're collecting data on that, and eventually we'll model all of it. Thanks, of course, to the work of Dr. Zing, my colleague. That was his passion, and he really did a wonderful job on this paper. I encourage you to review it, because this pattern actually is true also for double scattering beams. Okay, so we're going to move on right now to do actually hardware QA. Let's talk about QA with one-dimensional arrays. One of the commercially available detectors, and you've probably seen it at the IBA booth, is called a Zebra, the commercial name, but it's actually an MLIC device, or multi-layer ionization chamber, 180 copper plates. They actually measure the PDD and render it instantaneously for any beam and range combination. Very easy to use, convenient. You put it in, and then you just measure any beam depth you want for any aperture size you want. If you compare it to a typical, for example, TG51 water tank with one-dimensional motion, you can see that in order to check, for example, 3 different points along the PDD, you have to actually move the detector or the ion chamber 3 different points, and you don't really characterize the full PDD. So you need a device like that. However, the problem with it is just at this point, it's just way too expensive. If you have a double scattering beam and you have a moving scanner with an ion chip that can move, you can render those at a much slower rate. Uniform scanning, we're not that lucky because each layer is delivered at a certain the delivery is layer by layer, so you don't have this entire area delivered at once, so the detector is not covered by those at any given point the same way every time. So after a certain delivery, the detector is not detecting anything. So it's very slow, and it's impossible to do a meaningful PDD depth in uniform scanning, so we need a device like that. Here's, for example, the software that comes with the Zebra, and showing different measurements of PDDs, and the software is nice, and it gives you flatness values, range and modulation points for each one of those color deliveries. Notice something here: as you increase the modulation, the surface dose goes up. Look at this range and modulation beam here compared to modulated beam compared to this one here. More modulation, more surface dose. So clinically, if you want to treat, for example, parotid with a single beam, the skin and everything else is going to get full dose because the range will equal modulation in that case. So what do we get out of the MLIC? I mean, we have used the Zebra for a long time right now, and this data goes for 1 year from last year, showing that the water measurements of the distal end, or R90, is well within a millimeter, just like what Zebra has reported, and showing consistent delivery. So IBA system can deliver within a millimeter, and we can prove it, and it's well within our specs. Talking about two-dimensional arrays right now. Again, there is nothing except for the Zebra, really. There is no dedicated proton therapy QA devices, really. I mean, you just have to go with what's available in the market for proton therapy and adapt it to your own needs. Use the machine shop skills, people there to help you add maybe build up layers, handlers, something like that. In this case, for example, we have a holder just to hold the IC profiler. And we have another holder that holds the IC profiler at different gantry positions. So there's nothing really right out of the box. You have to, adapt it. But in this case, really here, you're just measuring symmetry and flatness. And what I'm showing here is a spreadsheet from our monthly QA showing the use of the IC profiler and measuring the X and Y field sizes, the symmetry and flatness, and these are our criteria showing that for this particular month QA it passed fine in one of our inclined beams. This is a trend of flatness for the same period, showing very consistent flatness within 2%. Symmetry is pretty tight, within 1%, using the same device. Now, one of the things we're very proud about in Procure is the work done by Dr. Ding, my colleague, on sort of adapting the RFDL QA3 device to do morning QA. What he did is he combined the QA device with a double-walled low-side phantom with a handle, and he added an index bar and combined this together as one detector. The RTTs carry the whole thing, put it in the table in the same position every day, irradiate a single beam, and remember all these tricks we talked about, how we add build-up so that we can maximize the use of the single beam. If you use any aperture, like the 10 cm aperture, it will be wide enough to cover 5 different minor units, five different ion chambers here, the central one for output and the other 4 for symmetry and flatness. Each one of those detectors that is used actually for morning QA warm-up in photon therapy already has some build-up, so that helps. One thing I didn't mention is that on top of the fact that he added this build-up and this low-side housing, he added fiducials in that little piece that the lip, it's just like a little lip that stands out. And the reason behind it, because in the morning QA, we just don't want to just look at the beam characteristics itself, but we want to also characterize the imaging system and see if the imaging system actually, is behaving in a consistent manner as well. So when you image the device, that's what you do first. You align the device to isocenter. You look at those fiducials. So these are the X-ray images. He actually scanned the entire thing without the QA3 device. So those are DRRs. And then you look at the sagittal and coronal DRRs and you match them to the reference point or to the reference DRR, and you get a correction vector. That correction vector should be the same every day. So with this device, you get one setup, one device, one beam, and gets you a whole bunch of things. It gets you the output from the central chamber. It gives you range consistency for reference range check, like R16 M10. It gives you a symmetry, and also it shows how well is the mechanical versus imaging alignment is. Because once you generate that correction vector based on the alignment of those fiducials, you ask the robotic arm to move to that position, and has to be the same position every day. So if you look at trends from this morning QA device, we have output, range, and symmetry, very consistent and within the tolerance limits that we expect. As I said, I mean, you want the imaging system to dictate the right motion for the PPS to move to within the Proton isocenter. So it's important to check that the PPS is actually moving to the same point every day. And this is XYZ motions that we built in initially, because when you put in that device on the table, it's offset by a certain X, Y, and Z, and then you bring it back to that position and record what the offset is. There are some outliers here when you do reference readings or baseline it, but pretty much the motions are within a millimeter, as would you expect from this highly accurate robotic arm. Another important test we do is actually collinearity test, in which we want to check that the imaging isocenter is equal to proton isocenter. We don't really care much about the protons. We don't care much about the lasers. The lasers have to be aligned, and we have other tests to line them up and actually prove how well they're aligned to the X-ray imaging center and the proton imaging center. But the most important one is to keep an eye on this. It has to be within very tight spec, within a millimeter. And the way you do it is really simple. And again, going back to being creative in your QA design of devices, you have a steel ball with a very well-known diameter that's put on top of a styrofoam cup, and then you got a film holder over here. You extend the X-ray imagers. You take an X-ray of this steel ball, measure those distances within the aperture to make sure it's aligned very well, and then you shoot a proton beam, and then you analyze the film, and the film isocenter and the imaging isocenter have to coincide and within a millimeter. And this actually arrangement allows for check of up to 0.1 millimeter or even more accuracy. So this is something that's easy, is done on a monthly basis, or whenever we somebody said, hey, well, I banged against, one of our RTTs against this, or it didn't extend well, or you suspect that there is divergence. Very easy test, but with very easy equipment to set up. So daily checks, these are the things that we do. Output range, software communication, of course, and imaging versus mechanical alignment. On our monthly checks, we add on top of that proton imaging isocentricity, or the collinearity test, flatness and symmetry, range and modulations, and mechanical. We do that for a few more beams beyond the reference beam. For annual, we do a lot more than that. We do PDDs and a combination of field sizes and gantry angles, and we look at also those rate dependencies. But we're just using the devices that I just presented to you earlier. So what are the challenges in actually proton therapy? As a physicist working in a proton therapy center, you probably need to be aware that just the nature of the beast is different. So the delivery modes also dictate how your QA device, or what QA program you want to instate and actually follow in your center. Depending on delivery modes, control systems are complex, so there's too many things to check for as well. We don't have a forum here. There's just very few clinical physicists out there, proton therapy physicists in this country. I mean, if you have 10 clinically operating centers, each one has maybe 10 physicists, you can have 100 out of thousands members of APM, so just very few. And the formal meeting that we normally go to is the PTCOG meeting, and it happens to be this year and the next 2 years outside the US, so I'm actually glad that the APM at least is giving the chance for us to present it for people who are thinking to, on getting into proton therapy. But things will change over time. PT systems are not robust enough. I mean, there is a lot of bugs, and it's not a secret. I mean, regardless of what the vendor is, we are as a field, we are in our infancy, basically. It's just things are working out. I mean, there's a lot of bugs, software, hardware, firmware, and all that stuff, and you just have to live with that. It does improve with time, and you can see it, but you just have to accept it. It's just the system is too complicated, too many things to control. And again, the QA system depends on the vendor system specs. If you have a room or a system that's completely pencil beam or uniform scanning, the QA program is different than a system that's only doing double scattering. Very similar, but it's different. And Hitachi system is different than an IBA system, and I'm sure all the single room solutions will be also different, and you have to think about what is the failure mode analysis or failure modes for that particular system or delivery, and design your QA system around it. There are no task groups. There is several in the process of being written and finalized, but the only guidelines you get is IAEA TRS 398, ICRU 5978. They're talking about the symmetry, but they didn't really talk about QA per se. TG40 and 142 are relevant for photons, but give you guidelines. What's acceptable also in photon wall should be acceptable in principle in proton therapy, and general publications. We don't have another challenge we have as proton physicists is that we don't have dedicated commercial QA devices. The only dedicated QA device you saw is actually built just for protons, and is that Zebra MLIC. I mean, there are in-house developed in some certain research institutions that develop their own MLIC, but they're not as robust. Unfortunately, because the market is very limited, these things are very, very expensive. In fact, they get expensive as high as $200K, and then that's how much money you would spend actually on supplying QA devices for an entire X-ray clinic. So, just for one, compared to just a single QA device for protons. So, budgeting for these things is actually potentially a problem, especially I can imagine that for single room solutions. It takes time to switch, tune, and deliver beam in every room. And this is not a problem for single room solutions, but obviously multi-room solutions, which are basically what we have right now in the US. Most of them are like that. You have to wait, especially if there's patient treatment. You can't really go and have to wait to ask for beam, and so things slow down. Your efficiencies go down. So you have to be smarter about your beam requests and what you can do with beam delivery. Again, the same point, the deliveries are sequential, so beam sharing is necessary. The cost is high, and I mentioned that earlier, for certain QA devices, but sometimes you have to make that investment because if they are robust enough, easy to set up, they give you reproducible results, and that's what you need. You need reproducibility. You need an accurate device that gives you the same reading every time. There is still this issue of multi-vendor software hardware. In our facility, I'll give you an example. The treatment planning system is different than the record and verify system. It's different than the imaging system, and it's different than the software that controls the robot. So you have 5, 6 different software, companies doing 5 different things, and they're all part of this chain of the treatment. So you can imagine that if one software is to be upgraded, you have to do regression testing to make sure that everything else above and below that software or communicating with that software is done. And that's not an easy matter because, again, we are in the development phase. We are still maturing as a field, so these upgrades are very frequent and much more frequent than what you expect in an X-ray clinic. I'm going to skip to the summary. Proton therapy systems are complex and require specialized equipment to measure various beam parameters. That's certainly the case. And therefore, it's imperative to make use of commercially available 1D and 2D arrays and adapt them to proton therapy to check routinely for beam parameters such as range, modulation, symmetry, flatness, and output, just like I mentioned in the talk. You have to also understand your imaging system and characterize it. You heavily rely on imaging because you image for every beam. So those X-rays and detectors are worked pretty hard every day. You get a check for your robotic positioning system. It's a highly accurate device. It's adapted for proton therapy for vendors that didn't make it specifically for proton therapy, like KUKA, and so you have to understand the system, understand all the corrections that goes into it. The motion depends as well on the accuracy of the motion depends on where you place the patient or QA device on the couch as well. So you have to understand all of that, and it takes time. to QA that and build a program around it to ensure consistency. Standardization of QA procedures for proton therapy is essential in establishing tolerance limits, and I'm hoping that the test groups are going to actually talk about that in the future because they are different for every mode of delivery. And by that, I would like to thank the contributors, my colleagues from the Oklahoma City Proton Therapy Center for their contribution to this talk, and thank you. Any questions, please?
Omar, thanks for a wonderful introduction to the field. I'm wondering, since you're adapting devices like the Daily QA3 and the Profiler, which were originally designed for photons and electrons, do you see anything that you might attribute to particle damage or maybe activation that's different from the cases that you would see with photons and electrons?
Surprisingly, not at the moment. I mean, these things are, we've been in operation right now since the end of 2008, and actually to tell you that if there's neutron damage or charged particle damage, believe it or not, we haven't seen that yet. So we did send them a couple of times, those QA devices. Each room has one of those QA devices, the RC QA3 RF back to Sun Nuclear for maintenance, part of our service contract, but I'm not sure, they haven't really reported to us back that there is damage or anything like that. Yeah. Any other question?
Yes. Follow up that question about the, hello?
Okay, sorry. Sorry.
Follow up the answer you mentioned about you have not seen any damage to your dosimeter.
Yes.
Do you want to clarify you're limited using, say, ion chamber type of detector, really didn't use a diode type of detector, or is all applies to all the detector you're seeing?
Actually, we rarely use diode detectors in our facility. No, we don't.
Okay.
So we exclusively use built-in ion chambers and regular chambers. I mean, pharma type chamber or pancake chambers, stuff like that. And those are the ones we haven't seen damage per se.
Right. So the comment I like to make is if someone thinking about using diode detector, for example, you need to watching out possible radiation damage.
I would agree, because this is well documented, I think, in the literature about radiation damage. Although I would think that they have very high tolerances, like several orders of magnitude of grays that you have before you even...
I didn't say we shouldn't use it, but everybody should really watching out how that can affect your results. Just the ion chamber, certainly, if you don't damage the electronics for the ion chamber, so probably very robust because you don't have anything else in there, just electrodes. But on the other hand, the diode, you sort of need to be careful to see what might could happen to your detector.
Very good point, Dr. Zhu. Thank you.
Omar, a very nice presentation as usual. How do you use your machine shop now, and how much do you outsource the range compensators and apertures, and do you have any recommendations for single room facilities contemplating doing machining?
Well, thank you for this question. We get calls all the time, and people come to visit our facility, and they talk about their plans and what they have in mind for the design of their facilities. And some of them decided actually to completely not dedicate any space for a machine shop, and some decided they will have 1 or 2 CNC machines. My take on this, based on my experience so far, is that you really need a machine shop. If you don't want to do devices, patient-specific devices, you still need a dedicated machine shop with a lathe and all the drill press and all the other things that you need, because all the other things that you find in a typical machine shop, and a skilled machinist, because again, even if you don't want to make the patient devices, which is fine, you can outsource them to some vendors like Decimal, or there are other I heard as well. You can do that. They deliver within 24 hours, but I think we designed it with the mindset that last-minute orders, which do happen, we process 10 to 20% at most of our needs with the machine shop, realistically. Now, also that changes over time depending on the complexity and mix. If you have, for example, 2 craniospinals that are being planned and they're being finalized for next week delivery, there's no way our machine shop will generate all these compensators and apertures for these huge fields. So we outsource them. The small stuff, sometimes prostates or anything like that, we can do it in-house. But the true value of the machine shop comes from the fact that they can do stuff for you because, again, nothing works really right out of the box. I mean, even for the Zebra that I showed you, we designed our own holder to allow it to be attached to the end of the couch and actually check for the PDD at different gantry angles. So you need a machine shop just for that. Oh, does that answer your question? Oh. Okay, thanks.
Do you have time for one more?
Yeah, absolutely.
So the output factors, how much of that is calibrating your monitor chamber versus other stuff? So you said that there was just change of response to the monitor chamber to different values of the range and modulation versus say like scattering contributions.
I think, well, the output factor. I mean, what you measure with it's output factor measurement is a relative measurement, so it doesn't really matter what kind of ion chamber you use. You could use a 2D array for that, or you could use a pancake chamber. The changes you see, if I understand your question correctly, in the trends that I presented are actually what you measure in water or solid water. So these are true measurements. I don't think they fluctuate that much. However, there are data points for very small modulation and very small ranges that sometimes do not follow a certain trend, and that's due to the fact that the scattering from the aperture and compensator, not from the compensator, so we don't use compensator, from the aperture, sometimes plays a role in that, and it's not necessarily reproducible, but again, it's in that range where we clinically don't care about it because we just mapped it out for the sake of completeness.
So it's the monitor chamber actually that's causing all those different trends you're saying in terms of the response. So it's
in the nozzle, correct?
Yeah.
And but I mean, you measure it also in water, and it's what you report. So we don't know if it's your question, I guess, would be, how do we know that the ion chambers IC1, 2, or 3 in the nozzle are behaving well? I mean, I guess we just have to trust the engineers or the vendor to keep them in check. But we deliver a lot of reference beams, and we always collect the same charge, so there is consistency.
Thank you.
Yeah. Any other questions? We have one more, maybe? Time for one more? Okay. Thank you.